Hello, my name is Nicole and I'm going to be presenting to you my oral presentation, Population Epidemiology and Concordance in Australian Children aged 11 to 12 years and their parent. I'd first like to acknowledge that I have no conflicts of interest to declare and that the Child Health Checkpoint study was supported by a number of large Australian grants, and that I was supported through my PhD with a scholarship and a small grant for the analysis of this particular project. I'd like to acknowledge the broader research team, including the Child Health Checkpoint study collaborators from the Murdoch Children's Research Institute, which is part of the Royal Children's Hospital in Melbourne in Australia, Professor Wake, Dr. Clifford and Dr. Lang. Then I'd like to also acknowledge my collaborators here at the University of Queensland in Brisbane, which is where I am today. It's not a virtual background, including my PhD supervisors, Professor Fords and Lalu. To give you some background on dental caries in Australia, in a national study of Australian children, we found that by adolescence, around half of Australian children had experienced dental caries in their childhood. And this results in obviously large costs to the healthcare system. So in a year, Australia spent around 10 billion Australian dollars on treating dental caries, which is approximately just under 7 billion US dollars. And despite this, we still have 1 in 4 children who have untreated dental caries in their primary dentition. So this warrants further investigation into not only what is currently influencing dental caries experience in Australian children, but we need direction as to how we can prevent this disease in children. So because the biological mechanisms of dental caries are very well known, social determinants are often looked to for the answers. And Fisher-Owens in 2007 quite nicely conceptualized all these complex and dynamic social influences on dental caries in children. And she described various child, family and community level influences of dental caries. In a systematic review that I conducted on Australian literature, family level influences was comparatively less researched, which has directed me to further investigation into this particular level. So family encompasses both direct and indirect influences on dental caries. For example, a direct influence is parental health literacy can directly influence what dietary choices they're making for their child, and also enforcing oral hygiene behaviours like toothbrushing. As I said, this influence in Australia is comparatively less researched. And dyadic analysis is fundamental in the investigation of the influences of interpersonal interactions and relationships like parent and child. So the parent-child dyadic relationship has distinguishable members. So there's a meaningful difference between the pair. This is different to, say, for example, twin studies. Previous oral health studies investigating within dyad relationships have found moderate correlations between oral microbes, hygiene behaviours and oral health related quality of life. So the Child Health Checkpoint study, which I'm going to be presenting to you some results today, aimed to investigate the influence of dyadic relationships on various non-communicable diseases, including oral health diseases like caries. To give you some background on the Child Health Checkpoint study, this is a nested study within a national cohort study run here in Australia called the Longitudinal Study of Australian Children, or LSAC. It was established in 2002, and they initially recruited a birth and kindergarten cohorts, so they were 0 and 4 at recruitment. The first wave of data was collected in 2004, and they collect data every 2 years through telephone and computer assisted interview surveys where they collect self-reported psychosocial, health and demographic variables. And so the Child Health Checkpoint was a nested study which ran between waves 6 and 7 of the LSAC study in 2015 on the birth cohort. They went around Australia and undertook a variety of health assessments, and they aimed to measure non-communicable disease phenotype precursors both in adults and children, and to describe the parent-child dyad relationships on a broad set of paired health measures. So a deeper understanding of the dyadic relationship of parent and children's oral health can help identify influences and set agenda for policy reform and targeted interventions, particularly at the family level. So the aim of this study today is to describe oral health in children aged 11 to 12 and their parents, including the distribution of various oral health indices and parent-child concordance in the Child Health Checkpoint study. So how the Child Health Checkpoint study worked was, at the LSAC Wave 6, there was 74% of the original birth cohort remaining, and 93% of them who were remaining in the study agreed to be contacted by the Child Health Checkpoint, and 53% of these subsequently participated in the Child Health Checkpoint study. When they went around Australia and visited all of these multiple sites, they took two-dimensional photographic images using a digital SLR camera, and they took views of the dorsum of the tongue fully extruded and two images with cheek retractors in, one where the child and parent had their teeth in full occlusion, and another where the teeth were slightly apart with both the incisal edges visible. So to assess these photos, because they are not a clinical examination, we had to carefully select the measures that we were going to use to assess these photographs. We selected a number of tooth, oral hygiene and orthodontic indices, and some of these included the Modified Developmental Defects of Enamel Index, the Modified Gingival Index, which is a visual scale to assess gingival inflammation on index teeth. Similarly, the Simplified Oral Hygiene Index visually assesses plaque and calculus on index teeth. And we also selected the aesthetic component of the Index of Orthodontic Treatment Need to assess whether the alignment of the teeth indicated whether they need orthodontics. So in terms of who was in this study, there were 1,874 families that took part in the Checkpoint study, and we had 1,417 and 1,419 parents and children have at least one oral health measure recorded. If the photographs were blurry, the flash failed, or the posterior teeth weren't visible, for example, some or none of the indices could be measured. Therefore, we had complete biological pairs on 1,396 of the participants. The study children on average were just under 12 and the parents 43.5. There were equal number of boys and girls, and participants' parents were majority female and the biological parent, so the mother. In 6 months, we assessed more than 10,000 dental photographs, and we counted more than 70,000 individual teeth, so quite exhausting. Let's go into the results. So on average, the children who were around 12 had on average just less than 3 primary teeth visible in the mouth and 22 permanent teeth. Comparatively, parents had around 26 permanent teeth visible. And we're having a look at the tooth measures on average, comparing the child and the parent. In terms of hyperplastic lesions, 1.5% of children had a hyperplastic lesion visible compared to 3.4% of parents, so a higher proportion there. In terms of any visible caries or restorations in the photographs, 5.5% of children had visible caries compared to almost 29% of parents. In terms of restorations, 11% of children had visible restorations, whereas 75% of parents had restorations visible in their photographs. If we have a look at their oral hygiene, in terms of gingival inflammation, only 6.4% of children had no visible inflammation, compared to 24% of parents. So when we have a look at the oral hygiene index, we only had 32% of children who had good oral hygiene compared to a majority of the parents, so 73% of the parents, which is quite a significant difference between them. In terms of the index of orthodontic treatment need, we had almost 10% of children who had a definitive need compared to 2% of parents. In terms of concordance, or the relationship between children and parents, tooth measures had overall weak correlations. The oral hygiene and orthodontic measures had overall higher concordance, and the largest correlation between parents and children was observed for the Modified Gingival Index, where you can see it's 0.49, which is quite high for a population level study in terms of correlations between parents and the child. In terms of orthodontic correlations, the highest was observed for the IOTN, which was 0.12. In conclusion, children had lower proportions of visible dental caries and restorations, and oral hygiene was significantly poorer than their parents. This highlights the importance of prevention in this group, as the delayed effect of poor plaque control and diet may have also contributed to the low concordance of dental caries. And parents' oral health, as you can tell, is in a significantly different life stage to their children. And gingivitis had the strongest parent-child concordance. And other dyadic studies have found associations between oral microbes and oral hygiene, therefore supporting the heritability of gingival inflammation. So screening for gingival inflammation in children and parents could and should be used as a risk assessment. And of course, this study does have limitations by using oral photography, as it may underestimate dental caries experience, as these were not validated by clinical dental examinations. But nonetheless, we selected measures that were used for their ability to visually assess oral health and describe oral health modestly without a clinical examination. So thank you for listening to my presentation. And we did generate a lot of data from assessing these dental photographs, and we had 3D facial imaging of the children and the parents as well. This data will become part of the broader longitudinal study of Australian children's public domain. So if you are interested in looking at this data, this information, or collaborating, please feel free to contact me.